So thank you so much for joining, and a warm welcome to some patient partners because this is a rare disease and they have decided to join us today. Um, so this is my disclosure slide, if it can go forward. And a special mention to Medtronic. So our story really starts with a 28-year-old social worker, and I put here fit and well until July 2015. She was into skydiving, active, into a lot of outdoor activities, and was contemplating starting a family. In August of 2015, she ends up in Estevan Emerge in one of the local hospitals with right-sided flank pain radiating to the groin. A CAT scan shows a stone that is obstructing the right ureter. She was seen by urology and underwent lithotripsy. So that resolved the pain. But 2 months later, she started to have the same pain and was absolutely convinced that this was a recurrence of a stone, only to go back to ER and follow-up CT scans showing no evidence of obstructive stones or any other urological causes of pain. And this is when things started to get worse. So if you can look at her lab results, renal biomarkers, the only thing that is abnormal is presence of hematuria. Investigations such as cystoscopy was normal, including multiple multiphasic CT scans, MAC3 scans, numerous ultrasounds. And by the time she came to see me, she was on, within 4 months really, 100 milligrams of morphine, oxycodone, Lyrica, and gabapentin. I guess, there's some overlap here. And she was unable to walk, housebound, anxious, depressed, off work. So the condition that she has is called loin pain hematuria. To say that this is a debilitating condition will be a disservice. This is intense pain, intractable pain, and it is pain that is coming from the kidneys with no obvious urological cause. The prevalence is 1 in 100,000, which is about 10 per million. And I suspect it is due to the fact that it is a diagnosis of exclusion, so it's probably underappreciated and underdiagnosed. Majority of the patients within a few years are on heavy doses of opiates. Not only they're depressed or work, but some of them are actually contemplating suicide. So patients that present to us will come in one of these 3 scenarios. The first one is a scenario that I talked about in my patient where she came in with the kidney stone gets removed or passed, and the pain persists. So this is by far the most common scenario. The second scenario is a patient who's doing daily chores, working at home, working on their computers or something like that, and then suddenly they start to notice flank pain. They initially assume it's a muscle spasm, go to their family physician or primary care providers, notice just blood, gets treated as an infection, no response to antibiotics, and the pain continues to get worse. The third scenario is something that we haven't seen, but it's an athlete who practicing his and her sport notices gross hematuria and flank pain. They stop playing the sport, but the hematuria persists and urological investigations are negative. Now you realize, you probably will notice that I've highlighted pain in bold. And that's because this is profound disabling pain. To make a point, my patients tell me that imagine being in labor and having stones blocking both your kidneys. The pain that they are talking about starts in the kidney, and the pain fibers go through the periarterial nerves, through the lowest splanchnic nerve, dorsal root ganglion, all the way passing through from T11 to L1, all the way to the spinal thalamic tract. Pain relief attempts initially were all by surgeons, and most of the publications from, say, early 70s to mid 2000s were entirely from surgeons, urologists, intervention radiologists. And when attempts were made to interrupt the pain pathways closer to the kidney, the pain results were inconsistent. When they were made closer to the spinal cord, it also interrupted afferent fibers from other areas, leading to incontinence, sexual dysfunction, hyperhidrosis. And patients would often even ask for a nephrectomy And there are few people who choose to be on dialysis rather than suffer this pain. And as a nephron-sparing procedure, in 1982, Aber and Higgins in England came up with this technique where they took the patient's kidney from its current site and put it in the ipsilateral iliac fossa. Then an Australian group published, and more closer to home in London, Ontario, Burke and Chin presented a series of about 48 patients. It gives you about 70% pain relief over a long period of time. Even in the best of hands, this is an 8-hour-long procedure, and it requires about 5 days of post-operative stay. And these patients are not end-stage kidney disease on dialysis. They have sticky platelets, they have a perfectly otherwise healthy kidney, and there are case reports where patients lost their auto-transplanted kidney due to either arterial thrombosis or venous thrombosis. So that's really your best option prior to this new technology that really became available. It was available for hypertension management, and this is catheter-based, percutaneous, minimally invasive renal denervation. And the credit really goes to Murray Esler and Marcus Schlake from the Breaker Institute in Melbourne, who developed this technology. This technology takes advantage of the location of the afferent and afferent arterioles, so that they can be targeted intraluminally. So whether they are going up or down, they are in the adventitia or around it in the renal arteries. So in this instance, a radiologist has put a catheter through and threaded it all the way to the renal artery. As you can see that the electrode is sitting on the endothelium, and this is a cross-sectional image of the renal artery. And this electrode generates heat using medium frequency alternating current. The heat generated is actually well tolerated to the endothelium, but is quite toxic in the area that it generates and releases the energy. And the range can be as far as 7 millimeters. So this was the technology used. This is Medtronic, first generation catheter. This was the technology used in both Simplicity 1 and 2, and I'm going back at least a decade for this. We used the same technology in Regina for our single center Prairie renal denervation study. And this was looking at central blood pressures and pulse wave velocities in stage 3 and 4 CKD. Our study results were mixed, and later when RCT data on renal denervation showed negative results, there was an incredible interest in neural anatomy. And in this study, published in Journal of American College of Cardiology, there's 25 autopsy subjects, and the green is the nerve bundles. And as you can see, closer to the aorta, which is proximal renal artery, the nerve bundles are well distributed. I mean, there is 20% closer to the lumen, and then it's well spread out. But as you go closer to the kidney, and this is more distal and closer to the kidney, you can see the nerve bundles are more closer to the lumen. So if you're going to give denervation, you get more bang for the buck if you're closer to the kidneys than away from the kidneys, which is what was being done initially. So we were watching this unfold as we were planning our patients, and so for our patients, we used the Boston Scientific, at least in the initial studies, and this was 6 electrodes on a balloon-based platform. And initial hypertension studies did about 4 to 6 ablations, and we were very clear when we were discussing with our radiology colleagues and interventional radiologists, Dr. Goyal and later Dr. Naimuddin, that we would like to have at least 24 to 26 ablations. We did both sides because pain invariably comes on both sides. And about 2 or 3 procedures down, patients told us that the pain was unbearable despite receiving conscious sedation. And so we started doing the procedures under general anesthesia, and this added to the time and cost of doing these procedures. So our initial results were quite staggering, really. So the first 4 we submitted to AJKD, and subsequent 12 to KI reports. Nurse practitioner Geibel, who was part of the study team, called me right after the first patient post-procedure and said the patient is completely pain-free. and I initially shrugged it off as thinking it's peri-procedure anesthesia that, or conscious sedation that the patients receive. 6 hours later, no pain. 6 days later, no pain. 6 weeks later, no pain. And then as a group, at that point, Shelley, Dr. Garcia, the urologist, Goyle, radiologist, and myself, and then we sat together and we said, maybe we have a solution for these individuals, at least a short-time solution who are suffering for this intractable pain. This is the report on the 12 patients. McGill scores were 38.5 pre-procedure, and they went down to 2.0. As the pain improved, you can see the mood improved, and as pain and mood improved, disability indexes came down and patients started returning back to work. And so, and if you look at the quality of life, this is SF36. There's 8 domains in SF36, and all 8 showed an improvement. And so this was actually quite exciting for us at that point in time. We were aware, really, of, observational studies in the past. When they were followed by a randomized control trial, they didn't necessarily show stellar results. Now, RDN in blood pressure trials, venoplasty in multiple sclerosis, when I came in 2006, that was the big thing, venoplasty. And the government actually funded that study. Vertebroplasty for wedge compression fractures, pacemakers for cardioinhibitory syncope. So the list goes on where observational studies made sense, but the RCT really didn't show that much promise. So we wanted to follow this up with an RCT, and we were told by funding agencies to do a feasibility study first. So by then, Boston Scientific had stopped manufacturing the catheters and had exited the market. Medtronic had re-entered the market with a newly designed catheter with 4 electrodes, and they called it the spiral catheter. So this was their 2nd generation catheter. The problem was that the technology wasn't approved in Canada. So we approached Health Canada for approval. And so we went through this little dance. Health Canada would say, get REB approval first. REB would say, get Health Canada approval first. But we did manage to get approvals. And the first 3 were roll-ins because our radiologist hadn't used this technology before. And they were supervised by an individual that had come down from Medtronic. And the subsequent 10 patients were randomized between the 2 arms. And we looked at pain medications, brief pain inventory, and the usual scores that we've talked about. Majority female. This is a condition of younger women, unfortunately. And so the 10 were randomized into 5 intervention arm and 5 in the sham arm. And follow up at 6 weeks, 3 months, and 6 months. We lost 1 patient on both sides to follow up, and we analyzed 4. And then the ones in the sham arm weren't left, and we asked them to cross over and get the procedure done. And so this was the study design, really. And this was a feasibility study, so the numbers, as you can see. And the intention of feasibility study is to see, is it practical to do a bigger study? So if you can, so this is the patient demographics, the total number of patients here, roll-ins here, denervation patients and sham arm, as you can say, a disease of younger women, younger adults. You can see the difference between onset of symptoms, diagnosis, and undergoing the procedure. Majority had, all of them had normal GFR, none of them had proteinuria. But this is where we started to notice that in the RDN arm, the patients on opiate were about 7.4 years. This is mean use. And compared to the roll-in versus sham for 3 years. So basically, they're close to twice as much longer in the RDN arm. And then looking at the mean morphine use, then you can see that there was more morphine usage in the RDN arm compared to in the other 2 arms. And I'll talk about the randomization process. But let's keep that, let's keep that in mind before I take this any further. And so, so this is the roll-in. So roll-ins did spectacularly well. 6 months, 6 weeks, very little pain at 3 months and 6 months. There was a little bit of a range in pain, but the RDNs had, BPI, apologies, I should have said this, the brief pain inventory, 0 being no pain, 10 being worst pain. and so roll-ins, 5.8, which is the highest number that they had, come down to 0.83. So this is an 85% reduction in pain at 6 weeks and 3 months, 70. And then RDN had close to 35% reduction in about 3 months. And the sham arm, obviously you wouldn't expect. And I was a little nervous about the sham arm. In randomized control trials, when the patient is blinded, sometimes the sham does really well. And unfortunately, the challenge where Simplicity 3 really didn't take off. And so I was glad to see that the sham really didn't do as well. And when the crossover happened, then there was again a 50 to 60% response, at least in the first 3 months. And this is seen in RDN dosage, 35% reduction, 26% reduction in the mean morphine use, median morphine, equivalent, and some of them were on different drugs, so we had to create equivalents. Roll-ins again, of pain relief, and then when you had the crossover, about 60% reduction, 50 to 55% reduction in opiate use. So already we're starting to see a difference in observational studies compared to an RCT. This is a SF36, 8 different domains, but I'm just going to focus on pain for time. Again, 16.8, 0 is the worst score. They were at 16. Then RDN arm 30, 40, around 30. So, and then roll-ins did spectacularly well, and the crossovers from sham did reasonably well. So you can, and again in VAS, so this is EQ5D. This is a visual analog score. EQ5D has 2 major components. There's a descriptive component, which we're not talking about, but this is a vertical scale of 0 to 100. So we just basically ask the patient, 0 is your worst health, 100 is your best health. Where do you put yourself? And there was 111% improvement at 6 weeks for roll-ins, 66 for about RDNs, and about 58% for the for crossovers. And you can see in the sham arm again, you can start to see some improvement. So this was this is a feasibility study, and feasibility studies are really to understand the challenges that we can face. We're basically not trialists. We try to do a trial. And when we look back at our patients, when the results came out, because we were also blinded to the results, and we realized that we made a mistake when it came to randomization. So we were just giving the name and the age and sex to our collaborators in the interventional radiology suite, and they were randomizing based on an openware software, which we had provided. So we hadn't offered really enough stratification factors. For instance, we hadn't factored in their pain meds and their scores and all these things. And I suspect if we had done those stratification better, the patients would have been randomized differently, and the answers would have been much better, although we hit our initial goal of getting 30% pain reduction over 3 months, and also seeing that 80% of patients follow through. But I think these are some of the lessons that we gained from this RCT. The other thing that we gained was that patients with RDN especially had other concurrent regional pain syndromes. So they had pain in their lower back from a traumatic accident that had happened or something else, and they needed the pain relief medication for those other things that were going on simultaneously. And there was this hesitation really to withdraw from opiates because they wanted the opiates for this other concurrent regional pain syndrome. And also the initial studies were all Saskatchewan and Alberta based, and this was more a pan-Canadian study. And so there was a reluctance to withdraw from opiates because they would have trouble of their primary care provider to escalate the dosing if the pain was to return. So there were multiple factors that played in this. And so I think one of the things that came out is that these patients should be managed in multidisciplinary pain clinics. Nephrologists, and I talk about myself, I think we should stay away from pain. Really, we don't have the skills or the skills to manage pain. I think percutaneous catheter-based radiofrequency energy is safe and rapid treatment for LPHS patients. And I think we've seen some stellar results in at least the roll-ins and the crossovers. RDN is associated with improvement pain and some aspects of quality of life in a RCT. But I think this is important, that these patients should be in multidisciplinary pain clinics so that the drug withdrawal can be in a professional and a scientific manner, and rather than just expecting them to go home and say, just go, cut yourself off the medications. And some people, after 10 years of being on opiates, would struggle to do so. So while we were trying to relieve pain, we were also trying to figure out why patients have hematuria and why do they have pain. And so this is the current hypothesis, and this is a kidney in a healthy individual, and you can see there are no red cells here, and this is a kidney in a LPHS patient, and you can see that there are red cells described here. So the hypothesis by Lee Herbert, who's from Ohio and did a lot of work on this, and is currently retired, is that the red cells block the flow of the ultrafiltrate, leading to leakage into the interstitium. Now, this interstitial edema is transmitted to the capsule, and because it is transmitted to the capsule, patients have this intense pain. Now, this was published in 1996 and still considered to be the hypothesis, but I think our group, we never thought that was really the reason why they were having pain, because all patients with ANCA-positive vasculitis should then have similar pain, if not worse. Even, you can't go on call for a week and see at least, 8 to 10 patients with AKI from ATN. And these people have tubular epithelial cells causing these muddy granular casts. So I just don't think that makes sense. So we decided to have a look at the basement membrane on our patients. And for that, we had to get a biopsy. So for 14 patients, we did kidney biopsies. So these were patients undergoing denervation a few minutes later. So prior to that, Dr. Goyal would just take them and get a kidney biopsy done. And a single pathologist, Dr. Pune Dukahaki, he looked at it. So we just didn't want any variability. And she was our study partner on this. So majority of the patients had red cells and casts, suggesting that this was a glomerular bleed. And obviously, traumatic biopsies can do the same. But I think there's ways to figure that out, whether this is glomerular or due to trauma. So whenever there is that going on with these red cells in tubules, the focus has to be on the basement membrane. And as you can see, the basement membrane thickness should be between 250 to 400. And there were focal areas of thinning, and then there were focal areas of thickening. But if we were to compare these biopsies based on a paper by T. Bosch in 1989 that came in NEJM, that is considered to be the gold standard on how to measure GBM, we can say that only one patient had thick basement membrane and the rest had normal basement membrane. So, and then there was a study from Praga in Spain, Manuel Praga, saying that crystals, especially oxalate, and we didn't see any crystals. So this was quite surprising for us. So if you look at the electron microscope view of this, I mean, this obviously is the lumen and urinary space. So the GBM is really a blanket-like extracellular matrix that's situated between these two cells, endothelium and epithelium. And there are about 4 different types of proteins in here, I mean, major classes. And so if a red cell has to come its way from the blood into the urine, it has to go through, this matrix. And so, and learning from collagenopathies. So we decided to speak to our geneticist here with Saskatchewan Health Authority and said, would it be okay if we sent patients for collagen mutation testing? To which she agreed. And we were actually surprised to see that none of the 14 patients had mutations or variants in call4 A3, A4, A5. Now, this is a panel that gets done. And so the panel will look at certain specific genes at certain specific sites. But really, in that, this was completely negative, which was quite disappointing for us, because for us, if it doesn't explain hematuria, then it certainly doesn't explain pain as a consequence of hematuria. So this is when we went back to our initial patient. And you remember, I don't know whether you do remember, I said she was fit and well until July 2015. So this time we asked her, tell us what happened to you since the time you were born. So take us through your schooling, your preschooling, and everything else. And she said that she was a shy kid and had anxiety and panic attacks until the age of 3, since the age of 3. At 14, having migraines coinciding with parents undergoing divorce, and symptoms consistent with irritable bowel. At the age of 20, she went to Norway to work as a nanny, was investigated for asthma. Now, if you please keep an eye on these anxiety, migraine, asthma, they will come later on. And dad had a history of kidney stones and gout. Mom had anxiety, depression, chronic fatigue syndrome. And the brother was suffering from post-traumatic stress disorder and alcohol-related addictions. And after we spoke to her, it was a light bulb moment for our group. And then we realized really that we were not even asking the right questions. So our initial attempts were just for pain relief. But when we were seeing these patients, we were not even asking the questions. So the question really is, what exactly is loin pain hematuria? Now, I believe that this is an umbrella term for all patients with glomerular hematuria and pain. I don't think this is going to be one single condition. And over the next few minutes, I hope I'll be able to explain that a little bit further. Now, people in Wisconsin in a group believe that this is due to urethral hyperperistalsis. And there was a case report, not from Wisconsin, who looked at Cialis use. Now, it's a smooth muscle relaxant, helped the pain. It's also an up-to-date. And so they think that it's due to urethral hyperperistalsis. Is it renal migraine? And this was a concept this floated once. And even if you look at the initial paper that I've seen, this initial paper by P.J. Little that came out in 1967. And when an angiogram was done, there was pruning of these blood vessels. And so is this renal migraine vascular, a neurogenic stimuli leading to a vascular change? And if you were to speak to a majority of the emergency room physicians and ER nurses across the country, they will say LPHS is a somatization disorder. So what exactly is it? And so we thought we'll do loin pain hematuria, detailed phenotyping of LPHS versus isolated hematuria. Kudos to my colleague who's part of our group, Aditi Sharma. She created a questionnaire of about 110 questions. It was detailed phenotyping, and thank you to Dr. Sarah Luskovich for helping us with some of the pain elements. And Aditi also did pedigree analysis of LPHS and IH. So this was as detailed as we get. So we thought we will compare loin pain hematuria patients, 24 of them, with 10 of isolated hematuria, and then see what is the difference. Isolated hematuria is extremely common, and loin pain hematuria is extremely rare. So where is it that the pain and the kidneys differ? And so when we did the detailed phenotype assessment, these patients, I was thinking that they'll have more chronic fatigue and fibromyalgia, but I was a little surprised when 14 or 24 had anxiety and depression, and 10 of those 14 had anxiety and depression preceding the diagnosis of LPHS. Kidney stones, as I've said, is the commonest. But at that point in time, these patients do not have kidney stones blocking the flow of urine, migraine, painful uterine bleeding, another common element, and irritable bowel, history of physical and sexual assault. I think we were the first group to show this, and a few others, endometriosis, and family history, so important. Mood disorders, kidney stones, diabetes. 5 had isolated hematuria, and 2 actually had loin pain hematuria syndrome. So when we compared LPHS versus IH, we can see that there was more irritable bowel, more depression, more migraine, physical and sexual assault, family history of chronic pain. So there's really a biological predisposition here that we really weren't aware when we initially started doing this. When Francisco Garcia and myself, we thought about this way back in 2015 or 16 at the insistence of Dr. Garcia, started doing these procedures. So this was quite interesting for us. And when we did pedigree analysis, we got really excited when this patient from Sweden, Stockholm, and this patient, I think from Arkansas, United States, they had strong family history. This one's actually quite the strongest. The patient female, her dad has the disease, aunt, dad's sister has a cousin sister, grandpa had isolated hematuria on both sides, and then this is the patient here. The patient's sister's daughter, niece, has LPHS too. So it's showing for the first time that there might be things that we can focus on and get some more ideas here, and what is driving blood in urine and blood in pain and pain from the kidneys. So this is a study that we've been doing now for at least a couple of years, and it's come to an end, thankfully. And so we looked at our hypothesis always since the last 3-4 years is that this is a mutation in the basement membrane. Now, collagen might not be, but there are other things that are in the way. There is 5 other proteins, and then there is endothelium, which has been very poorly studied, and then there's podocytes, which typically haven't been studied in the context of hematuria, because the assumption is when they get hit, you will leak protein at the same time. Now, our patients would always complain of pain at the site where the radiologist went in to have the procedure done, which is the femoral artery. So clearly this pain was so intense that it'll keep them off their feet for a day or two. So we thought this was probably an afferent pain amplification disorder of some sort. So we were always looking for gain of function mutation in the pain genes in the afferent pathways, or a loss of function mutation, the efferent pathways, because efferent pathways have a dampening effect on the pain. So we looked at 17 patients with LPHS and 10 with IH, and Aditi Sharma took a lead on this. And we initially identified 8,355 variants and 143 hematuria genes, coding for proteins that go from all the way from endothelium up to the podocytes, and eventually settled on this 65 hematuria variants. Now, to go through this will take some time. In the interest of time, you'll have to all agree that we found 65 variants, mutations from the endothelium to the podocytes, and out of the 65, majority of them are unreported. And this is what happens with next generation sequencing technology that we currently use. Generates a vast amount of data. So these are variants, novel variants, unreported variants, undocumented variants. They haven't been observed before, either because they are rare or because they occur in regions of genome that hasn't been extensively studied. So when we looked at these unreported, majority of these unreported variants were actually non-synonymous, SNV, so single nucleotide variant. So also known as missense variants. So these include a single nucleotide change in a DNA sequence resulting in the alteration of a codon that leads to a change in the amino acid sequence of the encoded protein. So likelihood of pathogenicity. Stop gain is a genetic mutation that results in premature termination of protein translation. And so, and then we have this frame shift mutations, and this is deletion of one or more nucleotides from the DNA sequence, leading to a shift in reading frame during translation. So by, theoretically, all of this can be leading to some form of damage to the proteins that are in this, above this, and beyond this. And so this is currently work under progress. We're going to be meeting with our collaborators to get a deeper understanding. And that includes Matthew Langtree from Hamilton. And so there were patients that had multiple variants, and this is LPHS 10 had 6 different non-synonymous SNV and 2 patients, and you can see that people had multiple variants. And then sometimes, even in the same gene, there were multiple variants, even in the same gene. So what does all of this mean in the context of hematuria? And how much of this is actually causing downstream damage to the protein? How much of that is actually contributing to hematuria will be determined over the next few weeks to months. In the same way, evaluation of the pain, I really don't go through pain as much but if this is the kidney, and for pain to go from the kidney to the brain, there are genes involved in transduction, TRP1, 2, 3, and 4. There are genes involved in conduction, sodium channels, potassium, and some of these channels are impacted, are already have therapeutic medications in use by anesthesia. The genes involved in modulation and synaptic transmission. So there's multiple things that can impact this. And so if it's an afferent pathway, is there a gain of function mutation? Or if there's an efferent pathway, is there a loss of function mutation? And when we did whole exome sequencing of 479 pain genes, there's about 182 pain variants that have been identified. Now, this is initial data, obviously. This is unpublished. And all 182 are non-synonymous SNVs, and majority are unreported. And so, and just a little bit more detail. We found 182 and 135 pain genes unique to LPHS patients. So again, I think we can't get too excited. We just have to sit with the right people, understand what this actually means, and how do we put this in the context of our patients, and what do we do when we identify that something like this? So really, initial hopes of finding a monogenic cause, one gene causing this problem, has now disappeared. And what do we do with the understanding gained will all determine in time to come. And so we're also doing a few other ongoing studies. We're a little short of cash. Otherwise, some of these would have proceeded by now. We're doing, based on the, you saw the one from Sweden and also from United States. So you can see that 10 patients of LPHS will be taking 2 of their family members and looking at the blood, looking at pretty much the same kind of pathogenic variants. We'll look figuring out the logistics of getting tissue samples from Sweden and United States, and the challenges, jurisdictional challenges that go around these things. And so what I think this will help us understand, especially the 2 patients that we talked about from Sweden and United States, will be quite helpful in getting a deeper understanding on this. We've, the protocol was actually published recently. We also have, proteomics. So this is where we are short of funding. 24 patients with LPHS, and we are also going to send some of the kidney biopsies that we had picked up for not for comparative proteomics, but just to have a look at what is the tissue showing at this point in time. So hopefully in a year's time, funding in place, we will be able to get a little bit more information. So let's go back to our social worker. So she started a family and now has 2 beautiful kids. She has completed 470 skydives. And all of that had been put on hold when she was struggling. She continues to travel and hikes a lot. She actively assists us in fundraising, and in a recent fundraiser, quarterbacked by Hospitals of Regina Foundation, she was quite active, and she remains a source of inspiration for us. I mean, when the biopsy studies come in and our shoulders droop, we speak with her, and she remains a huge source of inspiration for us. And for conclusions, this is glomerular hematuria. I think it might not be mutations in the collagen, but there has to be somewhere. Source of pain is currently under investigation. LPHS might be a CNS afferent amplification disorder akin to fibromyalgia, chronic fatigue syndrome, where there's increased predisposition to pain. But the pain clearly is coming from the kidneys, because when nephrectomy happens, pain disappears. And at least for 3 to 6 months, pain disappears when the pain pathways from the kidney are interfered or interrupted by renal denervation. 65 variants and 182, as I've showed you, have been identified. Now we have to go through this. And this was a huge lesson that we learned from our study: was patients with intractable pain are best managed in a multidisciplinary pain clinic, and nephrologists should frankly stay out of it. RDN is safe, and I keep on reading reports from time to time, and there's about potential damage in future, because the endothelium does get a huge hammering from denervation. Repeat CT scans in most of the patients who came back with pain have shown no evidence of renal artery stenosis. And so, but one of the things that is different about RDN in patients with LPHS compared to hypertension, and I've had discussions with this with Medtronic, is that RDN needs to be repeated in patients with in LPHS, whereas you do it once in hypertension. And in the ones who improve, and I think most people who've done RDN in hypertension will say 3 out of 10 improve and drop their blood pressures by greater than 30 points. And so but they are okay after one procedure. But here, I think they need repetitive procedures. We hope that this is our wish list, really, to have easier access to RDN. Things will improve if our financial status, our funding status story improves. We've learned a lot from the feasibility study, and we can apply some of what we've learned, especially when it comes to stratification and multidisciplinary pain clinics, and how do we treat, because treatment has to be more multidisciplinary rather than just a denervation and say goodbye, see you. We hope that we can classify Loin pain based on clinical and molecular genetic criteria rather than, so far, this is primary LPHS because we haven't found anything, and this is secondary LPHS because we found IgA nephropathy or a thick basement membrane. I think that kind of terminology should go, and then international registry will be awesome. Incredible kudos to superstar Aditi Sharma, and she's done great work. Our projects went on steroids the moment she started. Aarti Garg has recently joined us about a year ago and has taken over the entire clinical project, and very proud of her. Matthew Langtree Great source of inspiration for us. Francisco Garcia, who sent us the first patient and started it all, and is a urology partner. And our collaborator, Sarah Liskovich, helps us with pain and addiction more as a consultant. Goyal, who probably has done most denervations in Canada, about 60 or 70, and more recently, Dr. Naimuddin has started doing them, and we are truly grateful to two of them. Mohan and G, who do proteomics and genetics. A special thank you to Hospitals of Regina for their support, and Medtronic, and obviously some of our partners, including Otsuka, who have been quite generous to us. And so with that, I will conclude, and I am open for questions, comments, suggestions. So thank you for your time. Dr. Glassick, always lovely to see you.
Yeah, thank you, Dr. Prasad. It's always a pleasure to listen to you make a presentation on this enigmatic subject. And I must congratulate you and your colleagues for your persistence in attempting to resolve the uncertainties that exist in this disorder. And of course, it's especially gratifying to hear that we may have some therapeutic avenues to pursue in the future surrounding renal denervation. I do have a couple of questions. First of all, I think you are presuming that the hematuria in these patients is coming from glomeruli. Yet the glomeruli appear perfectly normal by all criteria, light microscopy, immunofluorescence, electron microscopy in most patients. The question is, your determination that this is glomerular hematuria is based on red cell casts, I think, seen in some biopsies and perhaps in some urinary sediments, but you haven't commented about acanthocytes. As examined in phase contrast microscopy, what percentage of the red cells during episodes of hematuria in these patients are acanthocytic?
Thank you. And the answer to that is we haven't examined them when they are actually having an episode. So these patients are not Regina-based. They live in communities outside of a town. So when they're having these episodes, they're going to their local hospitals. And so we are dependent on the information that is provided by the lab and not necessarily seen by us specifically in our institution. So I think that's the challenge. So
the in glomerular hematuria, exercise will exacerbate the hematuria in the great majority of patients. I wonder what would happen if you expose patients with loin pain hematuria syndrome to graded
I think clearly
exercise, say on a treadmill, and collected urine before and after graded exercise and examined them specifically for acanthocyturia. My impression is that if you saw increasing acanthocytes with graded exercise, that would be evidence in favor of a glomerular etiology of the hematuria, but red cell casts alone are not 100% specific for glomerular bleeding. They have been observed in patients with interstitial nephritis and even with acute tubular necrosis. Rarely, I don't mean to say commonly, but red cell casts by themselves are not pathognomonic of glomerular sources of bleeding. And of course, as you've stressed throughout this presentation, proteinuria is never seen in loin pain hematuria syndrome. So the other common manifestation of glomerular disease is virtually always absent in these patients.
I think
yeah.
Sorry. Regarding, does the hematuria get worse when they're subjected to exercise. I think there is real life examples. Patients really find it hard to move. Even going from the bathroom to the bedroom or going from point A to point B is quite painful. But I think we like your suggestion and probably take you up on take up the suggestion is that looking at acanthocytes pre and post, we can easily do that. That's a doable thing. And so thank you for that suggestion, Dr. Classic.
Many years ago, I had a few patients with loin pain hematuria syndrome that I subjected to DMSA scans. These are a form of radionuclide scans valuable in detecting small infarcts in the kidney, suggesting vascular occlusive disease, infarcts, renal infarcts, microscopic infarcts, not major infarcts. One of these patients, and only one, did have abnormal DMSA scans during episodes of pain and hematuria, suggesting that vasospasm, like migraine of the kidney with ischemic infarction, could be a source of hematuria and pain. It was only one case, and fortunately, this patient underwent a spontaneous remission of her loin pain hematuria syndrome. I still see her clinically 40 years later, and the condition is completely resolved, spontaneous. That led me to my final question. How often do you see spontaneous remission with loin pain hematuria syndrome?
So we have seen, I'm just going to rephrase the question. So we've seen people who were referred to us, and by the time we came to see, by the time we called them for a review, they said the pain had improved. Now, whether that was spontaneous remission is hard to know. The patients that we actively follow, none of the patients have spontaneously improved. They continue to have some degree of pain and discomfort. Some of them who have responded well, especially if we were able to offer them denervation early in their journey, have remained pain-free, and I suspect it's from disrupting the pain pathways. So I can't answer it because I haven't seen it. I haven't seen it happen yet.
Now, the patients who undergo sham RDN do get some improvement, but it's short-lived.
Yes.
You've never seen a patient get sham RDN and have a remission of the LPHS, right?
None of our patients had any improvement in pain scores or pain medications in the sham arm.
Okay.
I was very nervous about that because we were following the Simplicity 3 very carefully, and the sham component of the Simplicity 3 was quite staggering. And so because they go straight in, the radiologist goes straight in, only does angiogram. He's just short of doing the procedure. So this was recreated to the nth degree. And so I was literally nervous about that the sham guys will do incredibly well, and we'll run into some challenges. But
okay, thank you.
Thank you, Dr. Classic. So Garcia, you're next.
Hi, Bhanu. Thanks for presenting and inviting me to this. I think there's always a couple things that I always like to kind of reiterate, because I fully, again, agree with everything that we presented. And when it comes up the question of, is there some version of this being anxiety somatization disorder, unfortunately, I know that there's a good portion of the medical community that kind of turns their brain off. And I think it's really sort of something that we were unfortunately all taught in our medical education, that there is some sort of line that exists between our mental and physical health and self, which is really not the case. The more and more we learn, there's a lot of crossover. Wonderful example, of course, being I have a lot of work that I do in the sexual medicine world, that we have some good evidence that the best way of actually treating something situational, like a psychogenic erectile dysfunction, is actually to improve the erections, not to treat the underlying anxiety. And it makes a lot of sense because the problem is that the situational anxiety creates increased catecholamine use, which then shuts down the erection. So if you just make the erections better, then the underlying anxiety goes away. So there's a lot of crossover with this. And so I just don't want people to kind of discount and kind of write it off as something that belongs in the DSM and just forget about this after this presentation. The second part, which is kind of a little bit back to what kind of Dr. Glassock was mentioning, which is something that I've definitely noticed a lot when we're making these diagnoses, which is that there's a near, I don't want to say 100%, but there's a near 100% rate of people during the diagnosis that we do the split function renogram, usually LASIK supported, and they all have tremendous pain in the first few hours after that scan. It comes back totally normal, but they have a flare almost consistently, which I think really then lends to some degree of increased blood flow, increased function, causing some degree, whether it's congestion, expansion, stretch of that renal capsule, which is what gives them the pain. And I think that really lends it towards some degree of there being some physical action, and whether it's something along the lines of, is it a gain of function, loss of function of the neural pathways that's interpreting something that's a normal sensation as something painful that has been trained from a previous obstruction, such as a kidney stone, or is this something from previous experiences where there's changes in the nerve pathways and how they're interpreting that signal, creating a pain signal, maybe more akin to what we see in shingles, where somebody will have chronic pain after shingles and some people don't. Is there some gain of function or change that happens there? I'm not really sure about that part. But definitely with consistency, I always do see, and it's almost pathognomonic to me now, that if somebody has this high amount of pain after the split function renogram consistently, if they have LPHS almost
Yes.
without, it's almost diagnostic for me at this point.
Yes, I think that whole, the moment they get diuretic, they start to have pain. So fits with Wisconsin story of urethral peristalsis. RGH hemo, and then we will go to Devaney, who's been patiently waiting. So hemo, RGH.
Hi, Dr. Prasad. Thank you for such an informative talk. Our question is, how well were you able to manage pain with the off-label use of Cialis, and did you find that it was more effective than the use of narcotics?
So yeah, that's good. I haven't found any improvement with Cialis. We have to go through the initial patient hesitation, especially women when offered Cialis. They look at you with incredulity, but they haven't. And the ones that I've trialed, they've had nasal stuffiness, headaches, and no improvement in pain. And all of these have improved with renal denervation. All of these individuals have improved with renal denervation. So I haven't. There was one case from Isle of Wight. I think it's a small island between England and Ireland. And somebody had really history suggestive of urethral peristalsis. So I suggested that. And I got an email saying, thank you, the patient is now better, but there was no follow-up emails after that. And I've been trying to get hold of them again. So N of 1 with Cialis, we don't know whether they had any side effects, but N of 1. There is also a fella in United States who's looking at triptans, because is this a renal migraine, using sumatriptan for pain relief. We haven't done that. We have tried in a couple of patients in Ontario and Alberta and haven't seen any improvement also. I mean, obviously these drugs are expensive, not easy to get. And so that makes it a little bit harder. So the answer is, I haven't seen it in majority of the people, but there is actually a hesitation from women to actually take the drug. Devaney Mail, it's lovely to see you. Thank you for joining us. So we'd like to share some anything. We'd love to hear from you.
Yeah. So first off, I'd like to thank everybody for joining in and learning about LPHS. It is a syndrome that has greatly affected my life. So as you've seen in the patient case, my life with LPHS was not a life, to be honest. I went from being a super active 28-year-old hiking, skydiving, kayaking, doing all adventurous things with my husband, to not even being able to get out of bed. The pain was so bad, as Dr. P explained, that going to the bathroom would result me lying for hours on the bathroom floor just to get enough energy to go back to bed. When I was first diagnosed, I was a mental health social worker, and I actually had to quit my position because I couldn't go to work. Through renal denervation, I have completely got my life back. I am now a medical social worker with the SHA. So I'm working full time. My husband and I have had 2 children. We're back skydiving, back hiking, back kayaking. So it really gave me a second chance on life. So I could not be more grateful than I am for this procedure. I would like to add that being an SHA employee, I have never been more proud of this organization, the way I was treated in my own medical journey. A lot of people with LPHS are labeled drug seekers and are not provided medical care. Every time I presented to the ER, which was on a weekly basis for pain meds or going to see my own GP or anything, people always took me serious and always kind of said, we'll figure out what's wrong with you, don't worry. I only had one urologist who kind of wrote me off. And I think it's important to know that with conditions like this, because we are an exclusionary diagnosis, just because we don't have a test that checks all the boxes and says, yes, it's LPHS, please don't write us off. This one urologist told me, there's nothing wrong with you, go see a chiropractor, which would have done nothing for my pain. Luckily, my DP was like, no, there's something wrong. And he actually said, well, I'll send you to Dr. Prasad. He likes challenging cases. And within 2 days, Dr. P called me and said, I know what's wrong with you. And I was able to get treatment. And like I said, my life went from pretty much existing to being fulfilling. And, you know, not only in my personal life with my kids now, but with my professional life, I'm helping our community. I'm working in the healthcare field. So yeah, I could easily have been one of your coworkers, one of your relatives. And it's so important not to write us off and to label us as drug seekers, because we're not.
Thank you. Thank you, Daphne.
Thank you.
Thank you so much. Cassandra, I think you've raised your hand, and I'll then go to Ashley Stanton.
Yes, actually, I just wanted to say also, incredibly grateful to all of the research you have done. I am also a patient who had a renal denervation with Dr. Prasad's team in Canada, and it was a complete game changer. And one of the things that she just spoke about a lot of patients being dismissed or not believed. So many are labeled as drug seekers, and I'm a member of a group, a support group for LPHS patients, and it's shocking the number of patients who are suffering. I also think it's a very underdiagnosed condition because, like we've discussed, there is no specific test where you can go and just boom, take a blood test or do a genetic sequencing and say, yes, the patient has LPHS. So the road to diagnosis, being that it is a diagnosis of elimination, is a very brutal road. The number of tests and procedures that we are put through, as some are considered minimally invasive, I would actually call them medieval. And almost every patient, LPHS patient I've ever spoken with, suffers from some form of PTSD from the medical profession. They do. It's really, it sounds crazy, but you encounter so many doctors along your way until you finally find a doctor like Dr. Prasad, till you finally find a pain management doctor who understands and believes you and sees that you've gone from an extremely active person to being utterly bedridden in a matter of, my onset was microscopic hematuria post a radical hysterectomy and bilateral oophorectomy. And nobody could figure out why I had the microscopic hematuria. And then exercise-induced September of 2019, it was like hitting a brick wall. And in 48 hours, I went from functioning and exercising and still going about my life to utterly bedridden. And the renal denervation was a lifesaver. And I can understand, and it's very awful that we often see patients who disappear from the group because they have taken their lives. So the underdiagnosis that goes on and the lack of access to renal denervation, not just across the United States, but around the world, is so incredibly sad to see, because everybody's waiting for doctors available to perform this procedure that Dr. Prasad has created, and his team, and the research they've done that has just been, it's been a godsend to all of us. And we just pray that going forward, even though I no longer have the kidney pain, I can't let this go, because I don't want to see others suffer the road I had to go down. And I don't want to see more people lost, as they cannot bear this pain. And like Dr. Prasad said, to call it disabling is just, it's debilitating, doesn't even begin to explain it. I was a very active person. I ran my own business. I owned 9 different companies. 18 hours a day, 7 days a week, I was going. And to go from that almost overnight to being completely bedridden and incapable of doing anything, even sitting in the chair in my office for more than 10 minutes, was just devastating. So I really am so incredibly grateful to Dr. Prasad, his entire team. Aditi is awesome. And all of you who are on here learning more about this and considering hopefully offering these treatments to your patients and at other locations in the US and internationally is going to make a huge impact. And I think there are a lot more patients who are out there who are underdiagnosed and just dismissed and sent bouncing from doctor to doctor. And it's really something that you're doing God's work here.
Thank you so much. I just wanted to, I think Sarah Liskovich has got a time limitation here. Sarah, in your role as addiction and pain, the longer the patients are on pain relief medications, and in our case, the RDN group were on pain relief medications for 7 years, plus or minus 4, and they had about 180 something milligrams of morphine equivalent. Post-procedure, there was a little reluctance to come off. What's your views on that? And do you see this in your current line of work?
Yeah, so thanks for that, Bhanu. Obviously, Cassandra, thanks for sharing that story as well. It really does reinforce, the capacity issues, both for this condition specifically, and also just for patients who are experiencing chronic pain to have access to an expert team. So certainly patients who have been on long-term opioids become tolerant and do need access to chronic pain clinics and a specialized team in order to, even if the procedure is successful in terms of managing their pain, to then be able to taper safely off of their opioids. I do understand patients would be very reluctant to come off of opioids and or stop with a prescriber, because they would be worried about re-accessing a prescriber when there is acute pain. You can hear from patient stories here how difficult it is, and how the ignorance and the stigma around being on opioids. So I do think it is very important that patients do have access to that full interdisciplinary team. The chronic pain guidelines clearly state, any chronic pain guideline that you look at, that better care is managed when someone has an interdisciplinary team and access to the full menu of options, as well as an expert who is able to taper patients off medications when and if their pain condition is treated. There's lots of great resources out there, but at the end of the day, being able to access an expert and an expert team is such a critical piece, I think. And you hear from these patients, they specifically, they have champions like Dr. Prasad and Dr. Bolton at the Chronic Pain Clinic, someone that they have made a connection with, and that's one of the key pieces for them to successfully come off of pain medications and do well. So I think you need, those experts and those champions to do well.
Yeah, no, thank you so much. Thank you for helping us with the questionnaire, and thank you for taking an active interest. And we'll look forward to continue working with you, Sarah. I have Ingi Al-Saeed, who has hands raised, and then we'll be coming to Ashley Stanton. Ingi Al-Saeed, please.
Hi, thanks, Dr. Prasad, for the very interesting talk, obviously, and thank you very much for bringing the patient's perspective in. It's very important to hear from our patients about the impact of our interventions on their lives, whether positively or negatively. Great work, of course. But going back to what Sarah was talking about, and apart from the very interesting insight into the mechanistic elements of Loin pain hematuria syndrome, in terms of the management, you did reveal in your STAR patient's journey how her disease started with an acute episode related to stone management, which is a kind of many of the patients with Loin pain hematuria syndrome actually present. And in terms of chronic pain syndromes, many of those conditions do present initially with an acute element of damage that then leads to the ongoing chronic pain. You did mention the denervation and how impactful it was, but correct me if I'm wrong, I understand that you shared with us impact on improved pain scores up to 6 months following the procedure. In terms of chronic pain theories and development of chronic pain, it's well established that management of an acute pain episode successfully can lead to significant reduction in severity and actually an instance of chronic pain developing afterwards. And I'm wondering whether or not there is room for developing some form of a management strategy that includes acute early referrals following acute presentations with any urological condition that is associated with pain that may eventually become quite useful for management of some of these patients if do develop Loin pain hematuria syndrome or any other syndrome that is actually associated with this debilitating pain long term. I mean, at the end of the day, we do recognize that this group of patients can be particularly worried about the impact of such pain on their quality of life. But then again, patients with renal calculi and multiple presentations may very well have the same limits in terms of quality of life and same impact on pain, albeit due to a physically more recognizable condition than the Loin pain hematuria syndrome. I'm just wondering whether or not, as part of your management, we can start looking into earlier referrals from an acute pain perspective, as opposed to waiting until patients have already developed chronic pain, which becomes a lot more challenging to manage long term. Thank you.
Yeah, so no, thank you so much. I think this is a research study, so there are certain limitations in how patients get put into the research study. This is also a Health Canada approved study. So if you're going to give LPHS patients adrenal denervation, it has to be approved by Health Canada and prior approvals are needed. If we're going to change the number of patients that are undergoing the study, then ethics board will have to be informed and appropriate changes made. So there are certain limitations to what can be done. Hopefully, once we have overwhelming evidence that RDN works, if we were to have like 60 or 80 patients randomized into 2 arms, and then we see good grade A RCT evidence, I think institutions will then be forced to use RDN as first-line therapy. And I think it is then at that level that we can bring in these pathways for early referrals. There is no urological cause and the pain is coming from the kidney, get them to do renal denervation. And so, yes, I think you have it spot on, but it's a little bit more downstream at this point.